unsmoked a 10-inch long iron rod from Bhuvneshwar Singh's skull. The 30-year is more than lucky to have survived a near-fatal accident. He fell off his motorcycle onto a roadside railing in Mathura.
Yes, he was extremely lucky in the sense that even a millimeter shift of the change in the angle of the rod when it was going inside the skull and the spinal cord, even a millimeter change would have resulted in a catastrophe, even cardiac arrest at the site of the accident.
While half an inch of the rod was visible, CT scans revealed it had penetrated right through the middle of his eyes, through his nose and throat till the base of his skull, breaking 2 cervical vertebrae.
And actually this is the vertebra which is fractured while hanging. Someone, when you have the death sentence and hanging is done, that's how somebody dies actually.
Brought to AIIMS almost 10 hours after the accident, a team of 15 doctors and paramedics took over 11 hours to remove the rod. First, an incision was made in the mouth to allow access to the rod inside the skull. Next, some of the bones were drilled to make space for the rod to move. Once loosened, the rod was then slowly pulled out from the outside, millimeter by painstaking millimeter. The smallest error in the angle could have led to paralysis, bleeding of the brain vessels, even cardiac arrest. Surgeons also fixed the 2 broken bones at the neck to stabilize his spine, but Singh is still in the ICU.
This is the 10-inch long iron rod that pierced through Bhuvneshwar's skull. It's 3/4 of an inch thick and it's a pure medical miracle that he survived. But he would have been spared of this trauma if only he was wearing a helmet to protect himself. This case must serve as a cautionary example for others. In New Delhi, Shalini.
Thank you all very much for your attention.
Well, thank you, Professor Misra. I think by now you have come to know about the scenario of trauma in this country. And Professor Misra is not only the director of AIIMS New Delhi, but he is the helmsman of the trauma for this country. Particularly, he has established the role model. So we could come to know about the population scenario, increasing fatality rates 2.5 times higher than US even, and we could come to know about the role train accidents and scarcities in field of particularly rehabilitation training programs and establishing the other centers. Well, Professor Misra, it was wonderful talk. For the sake of buying time, I will switch over to the next speaker, who would be speaking on two-wheeler safety, burning issue in East Asia region by Dr. Rohit Baluja. And just 2 words about Dr. Rohit. He is the president of Institute of Road Traffic Education and chairman College of Traffic Management. He is dedicated professional working towards the reduction in road traffic death by education to the drivers, police personnel and scientific road modeling. Dr. Baluja, please.
Mr. Chairperson, Dr. Misra, our colleagues and professionals from the public health arena, distinguished ladies and gentlemen. As Dr. Misra mentioned, that we are all struggling since 2011 to 2020, our decade of action for road safety, that we want to reduce the growing injuries and fatalities by at least 50%. And one of the big problems is that globally 23% of these deaths are occurring because of two-wheelers. There are two-wheeler riders who are succumbing to injuries, and Asia totally accounts for 34% of this problem. And we believe that unless we really address the problems of two-wheelers, we will never be able to succeed in our efforts. If we look into the constitution of two-wheelers, you would see that in the European region it is only 2.4%. America means America and South America, all the countries together, 23%. And Asia Pacific is 58%. United Nations is divided into various regions, and at the Asia Pacific region, which is this region you see in green, we actually account for 60% of the total road fatalities in the world. And it is my privilege that having a roster status with the United Nations, I am representing or being the observer for this region, Asia Pacific, at the United Nations Working Party of Road Safety. If you look into the red portions, these constitute the two-wheeler deaths, and you see that our region here, the Western Pacific, you see, and the Southeast Asia, you see that the red portion is much higher than anywhere, any part of the world. And so we need to look into this region in specific if we need to reduce the burden of two-wheeler injuries. Dr. Mishra pointed out recently that this is the latest figures, that 141,000 people died in road crashes officially, as we come to know. And across the region you see that many states like Tamil Nadu, Maharashtra, Andhra Pradesh, Uttar Pradesh, these states actually lead with over 12 to 15,000 deaths per year. Much more worse is the injury. We have 2.6 million estimated serious injuries in this country, and we have no data, nothing to provide what would happen to these 2.6 million. How many would have succumbed, how many would never be able to live, and how many hundreds of thousands of families are getting into total poverty, which is a main cause of worry. Unfortunately enough, serious accidents are not registered to the tune they should be. We register about 500,000, although there are 2.8 million as the Planning Commission we have said. And that's another worry, that what is happening to those people also is something, a large cause of worry. The government figures, since there is no scientific investigation of accidents in this country, we say that 95% is because of road user fault, and which is absolutely an untrue assumption, but that's what the data reveals. Once again, we see that who are the killers, who are dying of road injuries in India is two-wheelers with 27%, almost 39,000 two-wheeler riders, co-riders die because of road crashes involving two-wheelers. Now this is very high, and unfortunately enough, we are not able to do something specifically involving two-wheelers. And again, when you see on a total figure that almost like 5 and for 39 and 19, 58% of our people died below the age of 34 years, our youth. That cause for an alarm. When our Prime Minister says the country is constituted of the young people, we can't afford to lose our young people getting into road injuries. Let's come back to the Asian countries. The surveys now reveal that why do people get into buying a two-wheeler and why do people use two-wheelers? And though a lot of surveys are made, but one of our very important survey is that it is a poor public transportation system in these countries, which has led to the people getting into buying two-wheelers. What do we do with two-wheelers? While the European philosophy or the developed country philosophy is tourism, sports or enforcement, we use two-wheelers for transportation of passengers, cargo. We are now making two-wheeler taxis. We have two-wheeler school support system, two-wheeler ambulances, of course with enforcement and tourism also. Coming to these countries, if you see that India has 72% amongst the whole vehicle is 72% two-wheelers, and Vietnam almost 95%. And most of these countries with Cambodia, Indonesia, Malaysia, Laos also following suit with very, very high number of two-wheelers. And once again, as you see below, in India we have 27% deaths on two-wheelers, Vietnam 79%, and Cambodia with almost over 50%. So helmets is one of a major reasons. But if you look into the type of two-wheeler usage in these countries, that's a study which I have recently presented to the United Nations, the white paper, and will be doing again in Brazil on 18th of November, that we need to look into the problems of two-wheelers. You look into Malaysia, they don't have, but they have come to understand that there is a need for segregation, creating two-wheeler lanes. And you see that the fatalities have also gone down when you look into the environment changes. Thailand, we have a major problem again coming with two-wheelers. We don't have a sort of a system of segregation, but we're working together with the Asian Institute of Technology in Thailand to see how we could do some research on this program. And when you come to India, you see there is again a total mess. There's no sort of an understanding of what traffic engineering is for two-wheeler riders. And so you see there is a total mix, not wearing helmets, and of course there are two-wheeler injuries and a lot of two-wheeler injuries. At the United Nations, the Working Party of Road Safety, we have a commitment, and we are working together to see how we could actually bring factors to reducing injuries. I presented to the United Nations that China has suddenly brought down these injuries, and how that China went and said that they should actually prohibit two-wheelers in major cities. And so 14 cities have actually gone into calling total prohibition of two-wheelers are very high, and they have started scrapping, in fact paying to scrap your two-wheelers. And they said that reducing two-wheelers will bring in discipline, noise pollution, air pollution, and theft and security and so forth. That's what a justification was there. And after doing this prohibition, we have seen that a lot of they have shifted from two-wheelers to buses naturally, and they have also increased the public transportation by 14 to 16 times. My question at United Nations was, can we do this? And all the countries said no, it cannot be done in a democratically controlled system like ours, political system. It is not possible to take away two-wheelers. So then do what? If we cannot ban them, what can we do? And so we at United Nations, with 11 countries from India to Indonesia, we are now, and I have been made responsible, I'm working with certain universities as well as their governments to first, we are saying, at least define what a two-wheeler should be doing. We have 150 countries across the world have signed to the two conventions of 1949 and 1968 at the United Nations, where they do not accept any of these things other than just two-wheelers with two people, but not on commercial usage. We need to change. We need to look at Asia. First important thing which we have recommended is please look at engineering. Today we have a 3-lane road and we have 11 lanes formed just because there are two-wheelers. So there is something gone wrong totally with the engineering patterns. We need to define traffic engineering. We need to define the lane systems. We need to define what speeds these two-wheelers would run, different type of two-wheelers. In India, for example, we have two-wheelers more than 125 cc, whereas you see Thailand, Malaysia, etc. is lower, 45 to 90 cc. And so we have a different sort of a problem, but we need to define it with engineering. We agree to what Malaysia has done. We want to create things where there should be total two-wheeler segregated lanes. Height of signals. You can't have a very high signal where you can't see. You need to have signages. You need to have road markings specifically, shapes and colors of road signs which we need to think of. Crash barriers. When we are falling, two-wheelers are following and hurting them, that's the time injury takes place. If we have soft barriers, perhaps it could save. Once again, Sweden took us away and Thailand took certain, they have done some working system. What happens at night? That's where we are much more, we need reflectivity. Two-wheeler training in India and plus all these countries, we believe that if you can ride a bicycle, you are as good as to understand what two-wheeler is. So no two-wheeler actually goes to a driving school. And so once you don't go to a driving school, you don't even learn the legislations or the art of defensive driving. And so we remain as a non-powered two-wheeler. And so we need to also look at type of licenses for two-wheeler riders. And apparel is very important. And we fall down in apparel, we also take the part of helmets, etc. system. Unfortunately, in India, once again, we follow the United Nations parameters of helmets, which are totally closed, and we don't wear them because they are too claustrophobic when you are wearing in situations like 45 degrees Celsius of temperatures and 90 degrees humidity, 90%. We need to have helmets. What Vietnam has come out with, shorter helmets, winds passing in, and so forth. So we also need research. Actually, we have very little research. The All India Institute of Medical Sciences has actually taken lead in providing research. The JP Research Institute, the Rajeshwari Medical College of Bangalore, the KIMS Bangalore, etc., and NIMHANS have got some basic research to understand what would be happening, but we need today data to say what is happening on helmet and non-helmeted injuries. At least we can take some sort of, and at United Nations we will be holding the first conference with South Asia Pacific region on 27th, 28th of February, where we would be talking about all these areas supported by the National Highway Traffic Safety Administration, the Centers for Disease Control and Prevention, and we are not talking of how to bring in a solution to these areas. 752 riders die every single day in two-wheeler crashes, and that's what we need to think, and today is the time for action. I take this opportunity to thank the All India Institute of Medical Sciences, specifically Professor Mishra, for having given me this opportunity to present this little study. Thank you very much, sir. Dr. Mishra, I would, Chairman, I have a course going on in my college. I will have to leave in the next 5 minutes. If you allow, if there is any questions, we could answer at this moment, or we could do that later on. Thank you.
Yes, so we'd like, in that case, for that fantastic presentation, if there were any questions, perhaps 2 questions. Yes, Dr. Satish.
Statistically it is less. I totally agree that a lot needs to be done and it can be something which is easily prevented. But their contribution to deaths is much smaller considered to the overall percentage of vehicles.
We have the concentration of two-wheelers is generally in the entire urban areas. While 63% of our people die on national and state highways, the contribution of deaths in 50 major cities is just 10%. And we don't have much of the usage of the two-wheelers on highways. So we have an urban problem, specifically.
Sir, I'm from Chandigarh, part of Punjab. Sir, you have talked about two-wheelers. Cycles are a big problem, bicycles. In Chandigarh city, we have separate tracks for the bicycles also. But nobody follows these tracks. So what we need, research is good, but we need to educate people to change the attitude also, sir. So some study on bicycles as well as tractor trolleys. They are dangerous to other people. The four-wheeler drivers, bicycles as well as tractor trolleys. Lot of cases, accident cases, come to PGI because of these. I'm from PGI, sir. So what is your take on this, sir? Education is very important. Helmet, if you are not wearing helmet, you are endangering your life. But we enforce it through chalaning, sir.
I think, please,
through education, sir, that is awareness is very important.
I think let us take the brief questions, because if we start discussing the scenario in our country, probably is going to take 1 more hour. So please be brief on this issue.
The character flows top downwards. It doesn't only revolutions flow bottom upwards. The development of an attitude of people is the responsibility of the government. We have given the government by the constitution the traffic engineering, they can do it. We have given them to develop the legislation. We have given the enforcement to it. And so there's something missing somewhere that we are unable to develop. So it is the government which has to take care of this.
A very brief remark, Dr. Barua. While discussing the engineering of the roads, please do not forget about the encroachment of the roads, which is very prevalent in our country. Because a decade back there had been several studies where the pedestrians were more prone for the accidents rather than two-wheelers even. Of course, the incidence was quite higher. Just a remark.
Thank you, sir.
That still exists. Pedestrians are the most vulnerable. That still exists. It has not disappeared. And what they are saying, education. Education is one, enforcement is other. So unless with education, enforcement must go hand in hand. Only education doesn't work. And it did not work even in developed countries. Enforcement, strict enforcement works. Now in Australia, the fine for drunken driving is 40,000 Australian dollars. So if you caught once, neither you will drink next time nor anybody known to you. So that is what has to be done.
So I was talking about encroachment more than enforcement and legislation. Of course that is needed.
Right. Thank you so much. On behalf of the organizing committee, Dr. Rohit Baluja, I will request Sri V. Srinivas, the Deputy Director Administration, to felicitate our speaker because he has to leave early. Thank you. I would request the chairpersons to continue with the session, please.
So I'd now like to move to our third and final speaker for the session before lunch, and that is Dr. Manjul Joshapura. Dr. Joshapura is an orthopaedic surgeon by training, and he's been at the forefront of highlighting critical gaps in trauma care systems in India and low and middle-income countries. He's currently the director of the Academy of Traumatology in Ahmedabad and president of the International Association, or YATSIC, International Association of Trauma and Surgical Intensive Care. Previously, he led trauma care at World Health Organization headquarters in Geneva. And today, Dr. Joshapura will be speaking to the accreditation of trauma services in low and middle income countries, the way forward. Thank you.
Thank you, Gerard, for this introduction. Good afternoon, ladies and gentlemen. I know I'm standing between you and the lunch, so I'll try and be brief and to the point, and I'll wind up my discussion and the point that I want to make in the next 15 or 20 minutes. We all talked about the prevention a little while back, but I want to bring back the focus on the trauma care part, where we have a stake, and most of the people here in this room are in the health sector. So this is what we'll be able to do. This is what we'll be able to achieve. Whereas the prevention and the road safety are desirable, prevention is certainly better than cure. But as you all imagine, it's a multidisciplinary effort, and it requires support from the police, the road engineers, the road builders, and road users. So this is a long-term strategy. Certainly we should focus there. But with what is within our reach, what we can do as a health professional or health sector, I'm going to take you through one of the approaches that has been successful in some countries in my presentation. What I'm going to discuss with you is a little background of the area that I'm going to talk. What is the evidence that this will work? The process and the parameter and the experience that we have a little bit in this country. And then I'll conclude with some remarks. So we all know that the trauma outcomes vary between the countries, between the high income, middle income and low income countries. I couldn't find the appropriate data from the East Asian countries which are present here. But this is good enough if you can replace the middle income country and the low income country with any of these, any of the countries in the Eastern Pacific region, the figure will not be different. If you look at the people who die, there's a great disparity between a low income country, Ghana, Mexico is a middle income country, and US of course. So you can see as the economy progresses, the mortality from trauma is getting less and less, and there are reasons for it. If you want to directly compare trauma outcome between a developed country and a developing country, this is a striking figure. You have 6 times more likelihood to die if you are in a low-income country with the same set of injuries. So there is a great disparity between the outcomes between low and middle-income country. And I think if you replace these 2 countries with any of the countries in the same income bracket in the region, this will not be greatly different. So why is that? What are the reasons for such a huge disparity in outcomes of traumatized patients across the world? There are a lot of efforts to address this disparity, and there is a lot of guidance from the Ministries of Health, the WHO, other agencies, and trauma care leaders to understand that there has to be an effort to uplift and strengthen the pre-hospital care, the facility-based care, to ensure that the system that we are operating in to bring the trauma care mortality down has to be optimum, has to be sustainable and standard based on the country that we are operating in. And there are a number of success stories to support that idea, and I'm going to talk about one of them. At this point in time, there's a clear need to improve the outcomes in LMI. We have a huge opportunity because, as we all heard, the burden is there, it is set to grow. Prevention efforts are being done, but they are not adequate. It is going to yield result in a long-term tenure. It is a huge economic loss to a country like ours in the region. And obviously, we need guidance for the all stakeholders. And how do we address this particular problem that is bothering us in our part of the world? It is a common knowledge that other than the resources, other than the countries that we have just seen, what are the key determinants of the trauma outcomes? So obviously the developed country and high income countries have better resources, better infrastructure. But what is more important, or equally important and equally pertinent to our setup, our setting, is the training of doctors and nurses, trauma team organizations to treat traumatized patients, protocol-based management, guideline-based management rather than the clinical judgment of individual practitioners, trauma registry and QI program. And one final thing that I'm going to talk is on trauma center verification process. I think these are the key determinants other than the resources which have improved the outcomes in high-income countries. There are a lot of lessons that we can learn out of this. I want to put before you a compelling evidence that has emerged from Canada. And I think it is very relevant for all of us to consider that. As you all know, Canada is America's closest neighbor, and almost 90% of the Canadian population live within 100 kilometers of the northern border of US. But until 1993, the mortality rate for seriously injured patients was about 4 to 5 times higher if you cross the border. So the major trauma centers in Montreal, Toronto, Vancouver had shown the mortality rate which was about 4 to 5 times higher than their counterparts below the border in US. So that was quite striking and very poorly understood. Why does so happen despite the resources and despite the the same infrastructure, similar kind of setup. Why is that the case? Therefore, they came out with a plan. So Quebec is a province in Canada. It has a population of about 8 to 10 million. So in 1993, when they started, they had about 50% mortality in civilian injured patient with an ISS score of more than 16. So what the government did was to accredit a trauma care center. They identified 4 hospitals as level 1 trauma center in the country. That was the only thing that they did. They made trauma care as their priority. And then over subsequent years, what they did, the hospital themselves, which were designated as trauma care center, what they did was to come out with guidelines. They had trained their staff, and by then the multi-specialty hospitals, which were designated trauma care center, within those hospitals, the trauma itself became a priority. And then number of steps were taken to develop triage and transfer protocols. There was designation of level 2 and level 3 centers in the country, in the province. There were also guidelines developed for pre-hospital triage and oversight of the medical doctors and so on. So in so doing, if you look at that, the mortality rate, which was about 40 to 50%, came down to roughly about 10% in about 10 years' time. It took about a decade for Canadians to match the trauma care outcomes to their southern neighbors. But the only activity they did was to designate the hospitals as trauma care centers, equip, resource, and understood the principles of trauma care system to bring the mortality down. And you will be surprised to know that all this costed them less than 1% of the health budget. So the idea that trauma centers could be very expensive, it's a resource intensive, it is a capital intensive exercise, which is not the case. I think the soft pieces of the activities that we do in and around trauma centers, that itself brings down the trauma mortality in most countries. So I think this is an important lesson, and this is a very compelling evidence for all of the countries at whatever level of economic development they are. I think this is one of the important lessons that we should try and learn and implement. So what could be the process and the parameters of LMIC? Clearly, in East Asian region, we are a heterogeneous bunch of countries with different economics, culture, religious barriers, and so many other things. So one prescription for all will not fit here, and we need to think out of the box to create our own parameter, our own standards, and own processes to identify and designate the trauma centers within our countries and systems. Clearly, all high-income countries, such as America, Australia, Canada, many of them are here, they have a set standards, set guidance from their professional colleges, professional bodies. For example, this is guidance from the American College. They have already guidance which are not applicable in the present form to our countries. So WHO has done some work to replicate those standards. Nevertheless, we still need to work out within ourselves to provide the stakeholders the guidance, and that can be done internally through consultation of stakeholders, the hospital practitioners, clinicians, government, pre-hospital care providers, and all those who are involved in the care of the injured, to come out with a guidance document as to what can be the standards and parameters to designate our hospitals as level 1 or level 2 or level 3, as the case may be. Clearly, there is a need for a political support. We might have to have legislation, regulation, and enforce them. Clearly, the big challenge is implementing all such standards and regulation if we come out of it. In many of our countries, there are other accreditation systems operating for the hospitals and for healthcare facilities which treat trauma patients, so there has to be an overlap or coordination between such systems if they exist to make sure that the hospitals get graded for their trauma care capabilities. So the process we need to outline internally and we to debate. But I think this is an opportune time to understand that. We all know what would need for a trauma center. Clearly, needs of a traumatized patient fall into any of these or all of these categories, and I think we well know the resources required to treat these injuries in the hospital. So the physical processes are easy to capture, and there's a lot of guidance available there. We had little experience working in Gujarat province some time back, where we internally discussed and created some guidelines. But I'm sorry to say that, with the change in the bureaucracy and the government and the political will, we could not take it forward. But there are standards, and there are sustainable, affordable, achievable standards even in our part of the world. In our countries with low and middle income, it is possible to generate some documents, some guidance, which we can all adhere to for different levels of trauma care. What we worked then was to create some general standards where the organization or the hospital has to demonstrate some commitment. We looked at the capacity for level 1, 2, or 3, the bed capacity. We looked at the hospital organization, the leadership, because many of our countries face challenge of public and private, and there are a number of private players mushrooming. So we need to make sure that they get in line and they get regulated and fall in line with the public sector services. Clearly, there are some specific standards which need to be adhered to for resources, education and training requirement for ATLS and such for all the staff, not once but on a periodic basis. And also the trauma registry and the QA process has to be built in to create the standard. And these are some of the snapshots that we created for EMS in city of Ahmedabad, where we tried to incorporate that. One of the things we looked at was very simple method to identify level 1 and level 2 centers. Level 1, for example, would have a facility of a CT scan, an ICU and the blood bank and the operating room, so that the head injury patients can be taken care of, and level 2 may not have the neurosurgical facility. So with very basic parameters, we could come out with some standards. The minimum bed capacity was kept at 100 beds because in case of disaster, the smaller units will not be able to accommodate large influx of patients. We also ensure that the services are kept as much reliable, as much affordable, sustainable as possible in the given context. So what we said is, although for level 1, all these services are required, but for level 2, we may not need the services of the plastic surgery or the neurosurgery or the pediatric or, such services which are considered to be super specialty where they can be taken